mode.
Thank you for joining us for today's webinar. This is Sleep, Fatigue, and Cognition related to traumatic brain injury. The presentation is sponsored by the Rural Veterans Health Access Program and provided by UAA, Alaska Center for Rural Health and Health Workforce, Alaska's AHEC. All participants will be on mute during the presentation. If you wish to ask a question, type it into the question box at any time, or there will be time for questions at the end. A copy of today's presentation can be downloaded from the Handouts tab in the sidebar. Now, we are joined today by Susan Maley, Program Director for the Rural Veterans Health Access Program, who will tell us about the RVAP project and introduce our speaker. Welcome, Susan.
Thank you, Pat, and thank you all for joining us today. We're very pleased to have Dr. Amy Murphy present on cognition, fatigue, and sleep for post-TBI. And I'll tell you a bit about the Rural Veterans Health Access Program. So this gives you the information about who funds us and how we're administered. And then our goal is to utilize telehealth and health information. We're working to enhance access and quality of mental health service and other health care services to veterans who are residing in rural areas. We're one of 3 projects in the country. And what we do to support this goal is provide services in different settings. And those include video-linked statewide availability of counseling. And this is with experienced mental health clinicians. As of September 1st, we've gone statewide and have a contract with a mental health agency to provide those services, also crisis intervention services. And these services are provided to veterans, family members, and other community members, as well as veterans. Today, we're focusing on traumatic brain injury. That's one of the RVAC's priorities for the primary groups served veterans and their families and caregivers, as well as other rural community members. And Alaska has a higher than national average rate of TBI. So to increase the care capacity in rural areas, the RVAC provides this training and other trainings for Alaskan medical and behavioral health clinicians and community health care providers, as well as topics on post-traumatic stress disorders. And we have previous webinars that are posted on our website. And we have a new website right now that's just gone up. I don't know whether this one is still active or not because we're changing sections, but you can contact me at my email and you see my phone number. And so we will have 3 of Amy's previous webinars up, as well as one on TBI and suicide prevention. So let me now turn it over to Dr. Amy Murphy, who is a rehabilitation physician as well as a certified brain injury specialist. Thank you for joining us today, Amy.
Good afternoon, everyone. So we've been doing rounds of webinars for traumatic brain injury, and for this round, for this fall, we decided to focus on getting more into the details of some of the major issues that can arise after traumatic brain injury. And for this one, we're going to be focusing on cognition, fatigue, and sleep issues. So the objectives for this lecture, we're going to cover anatomy very briefly just to kind of get an understanding of what different areas of the brain promote what functions. Physiology even more briefly, because I don't want to get bogged down into those details. We're just going to look at some of the current understanding of what occurs in the brain after traumatic brain injury. And then we're going to talk a lot about some of the medical, and by that primarily pharmacologic treatments that we have in our toolbox today, as well as equally as important, the non-pharmacologic treatments which we use to augment healing, as well as further studies, testing, and referrals afterward. So A lot of this lecture is focused on traumatic brain injury, and a lot of the studies that we have for some of the treatments that I'm going to be covering today also have been focused on traumatic brain injury. However, that being said, I do want to make sure to bring in the caveat that we're also using these treatments for similar issues and symptoms related to anoxic brain injury as well as acquired brain injury. So we are actually utilizing these with very good success, although I do have to put in the caveat that our research is based on traumatic brain injury treatment when we're looking at some of the different medications and so forth. So we're going to go into some of the anatomy, and really importantly, I just want to focus on some of the areas that we can find deficiencies in depending on which area of the brain gets damaged. So in these settings, we're looking more at more moderate and severe injuries, especially if there are any bleeds or bruising or contusions to the brain. And the frontal lobe is one of our big areas that we'll see because the frontal lobe is one of the ones more commonly affected, especially in high velocity injuries. And so you have your motor strip there, which can lead to weakness, can lead to total loss of motor. But there are also a lot of areas within this portion of the brain that can lead to some of the behavioral issues that we see after moderate or more often than not severe traumatic brain injury. So issues with just mood lability, social behavior, personality issues, as well as some issues with speaking, which is aphasia. The parietal lobe, less often affected than the frontal lobe. However, we do get some areas where this can be affected, especially in acquired brain injuries. And you can see there are a lot of issues with calculations, with inability to write, inability to name things, inability to understand the sequencing that you would do for just everyday activities. For instance, asking somebody to demonstrate how they would brush their teeth. And they are unable to put together those complex sequences to be able to show how that activity would be done. The occipital lobe works a lot within the vision sphere. We have a lot of people with severe injuries that do have difficulties with vision after their injury. You can also get hallucinations that are very different from psychogenic hallucinations, where there are things that are kind of imposed on the foreground or the background of what they're seeing, which is a direct result from their brain injury and from any injury to the occipital lobe, which again can be commonly involved in those high velocity injuries we had discussed previously. And then the temporal lobes. You'll see some different issues that can arise here. One of the things that I did not list is that if you get damage, especially deep enough in the temporal lobes, it can be a focus for seizure activity. But you can see some issues with aggression, some not only decreased interest in sex, but just a generalized decreased interest in all activities for living. Some memory issues as well as issues with speaking. And then the brainstem, which carries out quite a few of our automatic responses within the brain, such as things like breathing, heart rate, so forth. So you can see decreased respiratory vital capacity, issues with swallowing, a lot of balance issues, difficulties with sleep because some of our main pathways that regulate our sleep and wake cycles come through the brainstem, as well as some hormonal abnormalities that can occur with injuries to this area. And then the cerebellum, typically you're going to see a lot of issues with tremors, difficulty with balance, coordination. You can also get vertigo, which is the sense of room spinning around you, and difficulty with movements, especially rapid movements. So these are all different areas of the brain that can be affected, one versus the other in more severe injuries, some of them having bleeds and bruises, as I mentioned previously. You can also, of course, think about the extent of the functional loss that somebody with, say, an anoxic brain injury can get, because that typically hits all areas of the brain fairly equally. Because of loss of oxygen, loss of blood flow to the brain. So you can see how that would lead to a great deal of deficits after the injury, especially if it's a more significant anoxic injury. And what we don't have listed here is the white matter, which is the deepest areas of the brain, which provide the pathways between one area of the brain to the other. And so this lecture is going to be focusing on all levels of brain injury. And so it's here that I want to put in the caveat that when we look at more severe injuries, especially if they're high velocity, blow to the heads, you tend to find one area of the brain affected more than the other. When we're looking at anoxic injuries, that's more global. When we're looking at things like mild traumatic brain injury or concussion, we tend not to see anything that will show up, say, for instance, on an MRI, where one area of the brain is injured more than the other. But what we're seeing is that there is a physiologic change in the way the brain is actually functioning, and that tends to be more within the deep white matter, but you can see how, since that area of the brain connects all of these different areas of the brain, how that can lead to different deficits because signals are not passing from one to the other as they should. From a functional standpoint or physiology standpoint, a lot of the times we'll call it the neurotransmitter soup, because basically what happens after traumatic brain injury is there is a huge release of different neurotransmitters, and you have basically a brain that is sitting in an excitatory state, and so everything is out of equilibrium. There is no balance. And so I want to list some of the main players that we know are involved after traumatic brain injury. So we have some of these chemical transmitters are excitatory. They make signals perpetuate faster. They move the brain. And the main one that we have in our brain is glutamate. The main inhibitory one that we have is GABA. And so when you're looking at these two players, when we're looking at management pharmacologically, you're going to notice for those that we're not trying to do a hard stop or a hard on. We are not trying to make one move all the way faster or one stop completely, because we need some level of excitatory neurotransmitter in our brain. We can't just completely shut it off. We also do not want to make the brain completely inhibited so that it's not transmitting any signals. So with these, for medications, what we're looking at is more of a modulation effect on those. We have cholamines, acetylcholine being the biggest, and then we have catecholamines, dopamine, norepinephrine, and epinephrine being the three main players for that. And then some of our modulating neurotransmitters, which means that they can work to improve kind of the balance between some of the excitatory and inhibitory functions within the brain, serotonin, and then of course we also have melatonin. So on top of this, rapid release of neurotransmitters and then relative changes where they're not in homeostasis as they should be after brain injury, we then on top of that also have hormonal influences that come into play. And these tend to be longer acting and a little bit more difficult for us to treat on a rapid basis. And we're looking at the GAT, just basically stands for gonadal hormones, testosterone and so forth, adrenal, as well as the T for thyroid. So the problem is we have this complex system, and our brains, without any type of intervention, typically do very well with balancing one set of neurotransmitters against another, as well as balancing our hormones so that everything is in alignment. However, with a traumatic brain injury, you have an external force that has come in and basically disrupted the entire system. So timing is everything. We know from a lot of our different models that, we call it the golden year, which that first 12 months is where you can achieve most of the reprogramming and rehabilitation potential post-traumatic brain injury, although we know that we can continue to see changes and get improvements even past that. But definitely the first 12 months we see the greatest gains. So the goal is always to improve early recovery potential, because if we're catching somebody within this 12 months, we can get started with their rehabilitation, get them back on the right track, get them moving, and get them healed. And so what we come into is this balance between rest, which we know is what heals the brain, and rehab, which is what is going to retrain the brain to work around areas that are either anatomically damaged from the traumatic brain injury or that physiologically are not working correctly, and getting them to work in the correct manner. And that brings us to neurogenic fatigue, which is one of the biggest issues post-traumatic brain injury that we see. The problem with neurogenic fatigue is that you cannot push through it. It is not tiredness. It is not something that can be artificially, pushed through with things that we would use, such as caffeine and so forth, energy drinks. This is a state in which the brain has depleted its resources and it needs to refill prior to doing any further activity. And so this is what we're fighting when we're looking at early rehabilitation, because we know that there is going to be a component of neurogenic fatigue associated with brain injury. Cognition is the other piece that we're going to be discussing today, and this covers a variety of different areas. This isn't just things such as attention and memory. We're looking at things like initiation, which is something that if you have not had a brain injury, we take for granted, because typically when we think of doing an activity, it's pretty automatic that our brain takes that information of what we want to do and relays it in the appropriate manner so that we're doing the activity. It's a pretty seamless process and it occurs relatively quickly with very little delay time. However, after brain injury, this can be significantly delayed to the point of where if there's an issue with short-term memory, it can be delayed to such an effect that the person forgets what they were trying to initiate, because it has taken such an extended period of time. That also gets into processing speed, just the ability of how fast you can think. The idea of multitasking, which uses a lot of these different cognitive arenas in order for us to be able to basically switch our attention and our focus from one to the other. It can lead to symptoms of input overload, where someone goes into a busy environment and bright lights, multiple sounds, a lot of activity, multiple conversations going on at one time. It's too much input for the brain to handle whenever it is having this delay in processing speed and the difficulty with getting information both in as well as out. And so you'll have people, who have difficulties with headaches, people who have difficulties with riding in a car. Grocery stores can be very, very difficult to manage because you can imagine the high input that occurs in those environments. And then there can just also be the feelings of just feeling fuzzy, groggy, unfocused. And this mixed with some of the fatigue issues can just compound the problem. And sleep. Sleep is a very big issue after brain injury. We know that people have difficulties both initiating sleep as well as maintaining sleep. And that can be very difficult to treat. And the problem is that a lack of sleep will worsen both neurogenic fatigue as well as cognition. And so you get this interplay between the three coming together to create almost the perfect storm, which leads to a lot of issues with trying to work, do the rehab, and achieve both the rest that the brain needs to heal as well as the rehabilitation that it requires in order to understand and retrain itself to perform basic processes. So there are a lot of different ways that you will hear patients, refer to this, a lot of different ways you'll hear providers refer to it. A lot of people will talk about it as hitting the wall. There will just be a certain point where that's it. They're done. There's no pushing past it. A lot of times I will refer to patients as, it's basically as if you were driving a car and the car has run out of gas. There's no amount of pushing on a gas pedal that you can do to make the car move forward after the tank is empty. The other thing we can liken it to is a bucket. Whereas when you have a bucket and it has water in it, everything that you are doing is taking water out of that bucket. So whether it's a physical activity, whether it's a cognitive activity, or an emotional activity. So times of high stress will deplete somebody more quickly than times with lower stress, and so forth. And also, when you think about it, if somebody's having difficulties with sleep, what that does is it basically starts them off the day with half of a bucket. So they don't have enough of the reserves to even begin to start their day for the activities that they need to do. So much of the time when we're looking at neurogenic fatigue, we talk to patients about building up their endurance and promoting rest so that they don't get to the point where they are entirely depleted, because that can set them back for days if they try to push too far into their neurogenic fatigue. And so I'll just basically say, once you get to that point where you feel like the bucket is low, that's the point where you need to rest in order to allow it to refill. So we'll talk a little bit about the pharmacologic treatments, and there are some general rules of thumb. The first thing you want to do is start by removing any sedating medications or removing any medications that we know delay healing of the brain after brain injury. We start low and we go slow, and we start one medication at a time, because if you start, in most instances, because if you start more than one and there's a negative reaction, you don't know which medication caused it. We typically go with a medication, we call it the most bang for our buck. We try to get medications on board that will work on more than one system so that we can avoid polypharmacy. But at the same time, trying to remember the impact on the system. And we're especially going to see this when we get to the sleep side, and we understand how many of those neurotransmitters are involved in just the normal sleep cycle, and how many of these medications are working on these neurotransmitters and could possibly be while improving one system, we also want to make sure that we're not worsening another. After traumatic brain injury, there are multiple different ways that people can respond to medications. They're going to be more sensitive to some, lower doses for some. Always believe the patient regarding side effects, because their brain is now chemically different. They're going to have side effects that are not typically in the book. And so you need to be aware so that you can change either the dosing or sometimes remove the medication if it is creating such a side effect that it's offensive and not allowing the patient to heal. And education is key. So before I start anything, I try to let patients know as much as I can about what this medication is going to do for them, what are some potential things that we see as side effects, so that they can be aware and look out for them, as well as to understand where this is as part of their treatment plan. It's going to help improve, people staying on the medications, as well as improve dialogue, so that if there's something that comes up that is really bothersome, they know that they can get in touch with you and let you know, and things can be changed. So when we go back to looking at the different neurotransmitters, we're looking at, things that work on dopamine. So we had talked about initiation before. We're also looking at working memory, behavioral flexibility. That's basically the resiliency of being able to be in stressful situations and to be able to respond appropriately. It also works on decision making, as well as to some extent wakefulness. The noradrenergic system, you can see, also comes in with some of the cognitive piece, especially attention. It's very closely intertwined with the dopamine system. It also works on some of our automatic systems, which can include, some issues with heart rate variability, issues that people can see with oxygenation, as well as sleep-wake cycles. Serotonin is not just about mood after brain injury. Again, this is also something that works very well for improving cognition. And then, of course, acetylcholine for memory, as well as to a lesser extent arousal and attention. Glutamate and GABA, as I had mentioned previously, we're not looking for stopping or promoting primarily one versus the other. We do know that too much glutamate activity is one of the main things that can delay recovery from brain injury. So what we do is we try to work on inhibiting certain subtypes or receptors of this neurotransmitter, the main one being NMDA. Increases can lead to neglect, decreased neuroplasticity, decreased consciousness. And so what we're doing by blocking this particular receptor is working on improving consciousness, decreasing neglect, and improving neuroplasticity. GABA, which is again one of the main inhibitory neurotransmitters, if you have too little of it, it can lead to not just psychological agitation, but also to psychomotor agitation, increased excitatory states. And so what we're trying to do is we're trying to improve the transmission of this to decrease agitation, to decrease some of those excitatory states, but also to not go into a place where we are sedating the patient. And then melatonin works with more than just sleep patterns and circadian rhythm. It can also work with core body temperature, and you will hear complaints from patients where they feel like their core body temperature has changed, and typically there's a decreased ability to tolerate cold or hot weather, some of which can also be involved with hormones, but this is also an important chemical to understand that can be involved. So dopamine. Dopamine is one of the main chemicals that we are utilizing at this point in order to help promote recovery after brain injury. And the way I liken it to patients, I'm like, you have this bucket, and you know that it is important to keep it full and to not let it get all the way depleted. What we are doing with dopamine is we are giving you a bigger bucket. And so we are allowing more ability to not only cognitively recover after brain injury, but also to decrease some of the issues that arise with neurogenic fatigue. Because again, we have this golden year. We are trying to maximize it. So we're trying to make sure that we are not pushing them into a fatigued or depleted state, which will decrease their healing, but we're also trying to maximize their rehab potential within this early stage. So an agonist is a medication that improves either the concentrations of this chemical or the way that it acts. And so I've listed some of the more commonly used dopamine agents that we have in traumatic brain injury. And beside them, if you see parentheses, I've also noted where they work on other systems as well. And so we're going to start with amantadine, because this has most of our literature is in support of amantadine for after traumatic brain injury. And this is all levels of traumatic brain injury. So we use amantadine quite a bit in the hospital, especially in the ICU setting, because what it does, not only because it just works on dopamine, but it also works on blocking some of the glutamate receptors, is it not just works on improving cognition, and it not just works on improving neurogenic fatigue, but this is also a medication that we can use to help with promoting recovery and getting someone to better level of consciousness state. We know that use of amantadine has been shown to improve the speed with which people heal from a brain injury versus placebo. We had a great study back in 2012 in the New England Journal of Medicine that has shown the efficacy of it in that manner. It also has been shown to decrease agitation on its own. We understand that after moderate and severe injury, agitation is one of the phases that we expect for healing after brain injury. So by promoting healing through these phases more quickly, amantadine can help decrease agitation, as well as by promoting cognitive recovery. People are able to understand what is going on around them. They're not typically in an amnesic state for as long, and so this can promote less agitation as they are healing. So this is typically a medication for, in the moderate and severe range, we will start before somebody is actually brought off of sedation. The other case in which we use it is in mild traumatic brain injury. It works very well for cognition and neurogenic fatigue after concussion. It works very well for things that we had spoken about earlier, such as input overload. As well as, just the overall feelings of being fuzzy, cognitive delay, difficulty with just return back to work or return back to school due to the above issues, and especially neurogenic fatigue. So this is a medication that we use quite often in all levels of brain injury. And if there is one medication that we can say has really become the forerunner in improving outcomes for patients after traumatic brain injury, it would be amantadine. I list bromocriptine here because there are some instances with moderate and severe injuries where, if for whatever reason amantadine cannot be used, we will try bromocriptine. Typically, it does not hit the NMDA receptors. This is purely just dopamine, so we don't get quite as much of a boost from bromocriptine as we do from amantadine. However, it is our second-line treatment. I list Mirapex here because we use it quite a bit for restless leg syndrome, and I just wanted to let anyone on who's a clinician know that this can be used in conjunction with amantadine. So by using the Mirapex, you do not have to forego using the amantadine. It hits different areas of the brain, and so we've used both of them together very successfully in our patients with traumatic brain injury that also have restless leg syndrome. Provigil is a medication that works on dopamine, and primarily what it tends to cover is just pure wakefulness. So it doesn't have as much of the cognitive effects and improvements that we can see with amantadine or bromocriptine. It is primarily used for neurogenic fatigue. I will use this with amantadine if there are any residual issues with either wakefulness or fatigue after we have maximized the dosing of amantadine. Ritalin and Wellbutrin are also listed because they do increase dopamine. They also work on the norepinephrine system, so we'll talk about them a little bit more in length on that slide. These are your primary players for some of your main recovery after brain injury. Norepinephrine in this system comes in for a close second. And we're going to basically start at the bottom of the screen. When we look at the medications that work both on norepinephrine as well as dopamine, and you will see Ritalin listed at the bottom. There's also Vyvanse listed. These are two medications that are used quite commonly for attention deficit disorder or attention deficit hyperactivity disorder. They work very well for promoting sustained attention. They do the same after brain injury. And so we will bring these medications on board along with the other, with amantadine and other medications to help with improving sustained attention in patients that are still having issues with that sphere of cognition. I list the Vyvanse because we now have studies that show Vyvanse is effective after brain injury. We did not previously. And especially with my concussion patients, I tend to prefer Vyvanse because it's less agitating than the Ritalin, just from my clinical experience. But by far the the wealth of information that we have as far as from a research standpoint is on Ritalin, and they are equally as effective for improving attention after traumatic brain injury. Wellbutrin I tend to avoid in moderate and severe patients because it does decrease seizure threshold. However, this is an antidepressant that can be used that has no sexual side effects or very limited sexual side effects, and can help with improving both mood as well as cognition, but to a lesser extent. The SNRIs work on serotonin as well as norepinephrine, and we have things such as Cymbalta, Effexor, and then we have another medication here, Strattera, which is a non-stimulant medication that can be used in ADD or ADHD. And so from this list, I just kind of wanted to point out that we know that Cymbalta, even though it's listed as an SNRI, does have improved, it does work on dopamine, it does help improve dopamine levels, especially in the prefrontal area, which is an area where we can see a lot of disinhibition, inappropriate behaviors, and so it's one that we tend to prefer versus Effexor. But these are medications that we can put in that not only help with the mood aspect after traumatic brain injury, but they also help with cognition. And more often than not, even if I have somebody who is not having issues with mood post-traumatic brain injury, this can still be part of their plan to maximize their recovery. I also list there is an antagonist to one of the certain receptors for norepinephrine, and this is prazosin, which does not work to delay or decrease healing or cognitive recovery after brain injury, and is actually a very good medication that we use to help decrease nightmares, and especially our military folks who have comorbid mild traumatic brain injury with PTSD. So I wanted to list that is, kind of where it comes into play when we're looking at all of these different neurotransmitters and we're looking at sleep. It is part of the norepinephrine pathway. Just as we have things that also help that are outside of the typical list that you would think of for norepinephrine, those being tizanidine and clonidine, which work on a receptor site, the same receptor site, and something that we can use with good effectiveness for anxiety post-traumatic brain injury. And so these are things to keep in mind. We tend to prefer tizanidine because it has less effect on blood pressure. However, clonidine is available, especially in patients that have higher blood pressure, as it can manage both. Acetylcholine and glutamate, I put them together. Really, acetylcholine from a standpoint of working on increasing this neurotransmitter. The main medication that we have for this is Aricept. And so most people will know of Aricept for use in dementia, and we're looking at working on improvements in memory. It works on improvements in memory the same way after traumatic brain injury, so we can add this in to help with that if it remains an issue. This is typically kind of one of our end line treatments that will be brought in last if that's still an issue, especially after getting testing done and seeing that memory has remained impacted. For the glutamate, we had talked about amantadine earlier because it works both on dopamine as well as on glutamate. The other one I'd want to bring into play is Namenda. Again, another medication that we know has been used in dementia. But Namenda also works very well in brain injury. It blocks the NMDA receptor, so there's a relative decrease in glutamate. There's not as much bounding literature for use of Namenda alone in traumatic brain injury. We tend to find it's Namenda plus something else that can be beneficial. So again, this is a medication that I will bring later on if needed, if we're still having cognitive effects. And so you can see from this listing as we're going on, how we're just adding more and more layers to the treatment plan. And this is especially important with people with severe traumatic brain injuries because there can be profound cognitive deficits and profound issues with neurogenic fatigue. You're not going to have the same level of polypharmacy after mild traumatic brain injury typically from that standpoint, we are able to maximize things with amantadine, and we add things like Ritalin or Vyvanse if there's continued attention issues or if there was a premorbid history of ADD or ADHD. Serotonin. We have a great deal of studies that support the use of SSRIs such as Prozac, Zoloft, or Lexapro that are mainly working on the serotonergic system. And as we mentioned previously, post-traumatic brain injury, this is not just for mood support, but this is also for cognitive support. Again, we have the SNRIs because we have less studies that look at these in direct treatment for traumatic brain injury. However, from a clinical standpoint, we know that these are working on more neurochemical sites. So if I have somebody coming in, post-traumatic brain injury, and I think that by using one medication, I can hit multiple different areas and multiple different domains to provide support for their cognitive recovery, this is something I'm going to use preferably over just an SSRI. So Cymbalta is one that, from a brain injury standpoint, is used quite often because, again, it increases dopamine in that prefrontal cortex, which is very important. It works on norepinephrine to help with some of that cognitive recovery, and it also works on serotonin to help with cognitive recovery as well as any mood support if needed. Strattera, again, not as much impact as Cymbalta, but this is one of your non-stimulant medications that can help with sustained attention. And Effexor tends to work very well, especially if there's a high anxiety component that's coming in from mood disorder after traumatic brain injury. So these are some of the things that we think of when we look at replacement for serotonin. And then GABA. As I had mentioned previously with glutamate, this is our main inhibitory chemical that works in our brain. And so there are some very important things to understand about the rules with how it works. So many times we will use anti-epileptic medications that increase this neurotransmitter. However, we really do not know in what way it's doing it. So you'll look at some of these other medications that are listed. They definitely have the subtype receptor of where they're hitting GABA and how they're increasing it. The anti-epileptic medications, they're working in some type of third order way that we're not entirely clear of. However, we do know that it works very well for overall just improvements in agitation after brain injury, which can be a very common and very difficult thing to work with, especially when you're trying to do rehabilitation or in the acute setting when trying to bring someone off of sedation. So Depakote is one of the main ones that we use. Depakote works very well for both the agitation component. We also like it because it has very good evidence for migraine management and people who have blood in the brain either from the bruising or just a separate bleed from their traumatic brain injury can typically develop headaches, and so this is a medication that takes care of both. We tend to avoid some of the older medications like Dilantin and Tegretol because they are very sedating, and we go toward the newer anti-epileptic medications other than Keppra, which does not work in the same manner as these, just for overall improvements of agitation and psychomotor agitation that you can see after traumatic brain injury. The medication class that we absolutely avoid are benzodiazepines. These work on the APM receptor, as you can see, and we know from a multitude of clinical studies that this delays healing after traumatic brain injury. And so really we say that it should only be on a medication list if absolutely necessary. For instance, if somebody is having seizures and it's listed for as needed to break seizures. But this should not be part of their regular treatment unless you've really, kind of talked to a specialist and there are no other alternatives. It is not a medication class that should ever be used for agitation or anxiety after brain injury, because you're going to worsen the overall prognosis and the overall picture because it's not allowing the brain to heal. You can see the other medications that use the same subreceptor type are Ambien and Lunesta. Now these are non-benzodiazepines. They are sleep aids, but we tend to avoid them post-traumatic brain injury because we know they're using the same receptor subtype as a medication that has been shown to delay healing. Specifically, we also avoid Ambien even in concussion patients because it tends to have a paradoxical effect. So it can keep people awake. It can worsen nightmares in anyone that has comorbid post-traumatic stress disorder. And so these are basically two medications that we avoid for use for sleep simply due to concern because they use the same receptor subtype, that there may be any potential delay in healing. Baclofen is also works on the system. This is a medication we use for spasticity after brain injury. And so again, it is slowing the system down specifically in, it's a central depressant, but it works on helping to decrease any increased tone that can occur after brain injury. And so this is a medication that you'll quite often see on the list for patients who have had significant brain injuries that result in spasticity. And then alcohol is our other second, I guess you could call it, class of substance that will delay brain healing after traumatic brain injury. This is an indirect agonist, indirectly increases levels of GABA. So that, along with benzodiazepines, are the only two known substances that will delay healing after brain injury. And again, I always caution all of my patients to completely abstain from alcohol, at least for the first year, but I recommend longer as long as they're in any type of active brain injury recovery and still making significant gains, because this is something that can slow it down. And then final thoughts on sleep. So all of the neurochemicals that we have talked about, plus histamine, are involved with the sleep cycle. And so primary sleep disorders aside, we know that definitely there's an increased risk for sleep apnea post-traumatic brain injury, and all patients, especially with significant brain injury, should be referred for a sleep study to make sure that there are no primary sleep disorders that could be involved in muddying the picture. That being said, when you have a brain that has all of these alterations in neurochemicals, it is not surprising that there are issues with sleep. Melatonin is one of the mainstays for treatment that we use after brain injury. And the overall recommendation from the Brain Injury Association is, other than melatonin, you want to start with non-pharmacologic measures. Now, I put start in quotes because really, in all honesty, we've already started using medications that we know are going to be having some type of effect on the sleep cycle by just utilizing medications that work on fatigue and cognition. So you're already starting and working on improvements for the sleep cycle just by working on cognition. Other things we look at are trazodone, which is an SSRI that works very well for sleep, and prazosin, as I mentioned previously, that works especially well for nightmares, especially in the setting of PTSD. Oftentimes, if those things are not working and non-pharmacologic management is not working and we know we need to get that person to have some sleep, we'll try using medications that treat multiple comorbidities. Things like Elavil work very, very well, but again, should only be used in the short term because we have some studies that show long term there can be delays in cognition. One of the things that I consistently recommend against is the use of Seroquel, which for some reason became very popular for quite some time, and I can still see it used in some clinical settings. But we know that it is an atypical antipsychotic. This is a medication that, yes, while it can help promote sleep, we also know that in animal studies, antipsychotics delay motor recovery post-traumatic brain injury, so we do not recommend its use. Non-pharmacologic treatments are just as important as the pharmacologic treatments, and that is very, very important to remember. All of these things should be occurring simultaneously for improvement in recovery post-brain injury. So initiating cognitive therapies, which typically we will get patients in with speech therapy, as well as if there's neuropsychology that provides cognitive therapy. It is extremely important to have the therapy piece because what we're doing with medication management is just providing the fuel, but we're not providing the direction or the rehab. Physical and occupational therapy can help. Occupational therapy does work on cognition. Physical and occupational therapy combined can help work on endurance and issues with neurogenic fatigue, helping that person get back to promoting the level of work and output that they need to in order to get back to life. Sleep therapy, cognitive behavioral therapy, neurofeedback, EMDR, especially in the setting of PTSD, are all things that can work very well for promoting sleep, as well as just basic sleep hygiene and education for the patient. And supportive therapy, especially if there are any mood issues or psychosocial stressors, which there can be quite a few after traumatic brain injury. Behavior modification is super important, and education for patients is part of what we do to help improve avoiding triggers, working on power rests, and just understanding neurogenic fatigue, what that means for brain recovery, and the overall importance of stressing endurance. You know, this is a marathon, it's not a sprint. And so working on getting to that place where they can basically get themselves back to where they want to be means taking shorter steps in the interim. And then diet and exercise, I always recommend that patients keep a journal so that I know exactly what level of activity they are able to do before they start having symptoms of neurogenic fatigue, as well as keeping track of their diet, because there are some areas of diet, some specific foods or food groups that can improve or worsen their cognitive status for the day, and it's important for them to understand and recognize those triggers. Additional referrals, as I mentioned previously, sleep medicine is a big one, especially after moderate and severe injuries. Up to 40% of patients can have a primary sleep disorder like central sleep apnea, and so it is extremely important to understand and to get that treated so that they can have the adequate rest for their brain to heal. Neuroendocrinology, especially for any pituitary-based injuries, because you can get some rather profound hormonal imbalances within that region. You can also work with gynecology and endocrinology for any issues with sex hormones or adrenal hormones, because remember, this is not just neurotransmitters that will get disrupted. These are also some very complex hormonal systems that can get off balance. Working with behavioral health, especially for any stress. There could have been premorbid stress, but definitely now after brain injury there's an additional stress, typically, and thinking of all of the psychosocial stressors from lack of work and so forth while trying to recover. Vocational rehabilitation, nutrition and dietitian, especially if there's a significant noticing of food triggers for recovery and for therapies, as well as different alternative medicine, so naturopath, osteopath, acupuncturists. Also, I have quite a few patients that have had benefit with massage therapists. Understanding, again, that chronic pain is another thing that depletes water from the bucket. So making sure that you're working from a holistic standpoint and understanding that anything that really takes away from the system is going to decrease the amount that they can actively do throughout their day, and getting them to a place where they can get back to life is by balancing, again, the neurogenic fatigue with the rehabilitation. So in summary, we have three systems that are, three different basically symptom sets that are really invariably entwined. They're all utilizing the same neurotransmitters, and then you have a hormonal system on top of it that can really disrupt the system after brain injury. And so you really have to approach this as a cohesive unit, as well as, this is a cohesive unit within that one person. So making sure that you're providing the appropriate support based on what they are presenting with at the time. You cannot just go with the pharmacologic management. Non-pharmacologic management in tandem is just a must. And just being very, very careful with the pharmacologic care so that you're avoiding polypharmacy, adding only what you need, but then really getting the gains that the person needs. So it's a balance of giving them enough medication so that they can make a significant recovery with not adding too much at one time so that it delays their recovery. And refer. Make sure they're getting in with therapies, getting in with the subspecialists that they need, and getting in with any other physicians that they need so that they can heal from what is a very, very much an injury that affects all areas of life. And then just providing support, both educational support as well as motivational support, because the recovery is a long road. And as much as no one likes to hear that it's going to be a year before they can fully recover from anything, it's important for them to understand that it's available and that as a group you're there to support them while they are on their way. And I have time. I've tried to save time for questions. If anybody has any questions, I'd be happy to answer them. I'm available also after our hour if there are any, ones that go past time.
Please go ahead and type your questions into the question box, and I'll be happy to read them out to Dr. Murphy. If for any reason we do not get to your question today, you can also send us your question to UAA_AHEC, AHEC at alaska.edu. We'll be happy then to forward them to Dr. Murphy, who will respond to you in that fashion. We have no questions that have come through so far. Susan, would you like to do any final thoughts?
Thank you, Pat. First of all, I want to thank Amy for this presentation and to say how much we appreciate the work that you've done in Alaska, both directly for patients and in training providers. So we will have this webinar's audio and PowerPoints posted within a month at the Rural Veterans Health Access Program website. If for some reason you didn't catch that web address, you can just Google State of Alaska Rural Veterans Health Access Program and our web page will come up. So with that, I just want to thank, and do you have a question now?
We do have a couple of questions that have come through. What issues do you see related to neurogenic fatigue and performance on neuropsychological evaluations?
Definitely that can be a big issue, but I think it's important for that actually to come to be because we're using neuropsychological testing in order for us to say this is what a person can do versus what they can't do so that we can work on kind of getting their plan together for how they can get back to work, school, whatever it may be. And so if they're experiencing neurogenic fatigue during the testing, you know they're experiencing that during life. So it's important for us to be able to see that, well, they did great in the first half of the testing, but then the fatigue kicked in and it just kind of, sputtered out. Well, that's important for us to know because that just, means that this is an additional step that we need to take in order to get them back to full recovery.
One other one is please define power nap or power rest.
Oh, absolutely. So that is, that's a great question. And really that's defined by the patient themselves. So not all patients feel that they need to sleep in order to recharge. What I typically say, it's anything that they can do in order to kind of decrease their input, decrease their output so that they can provide brain rest. And so this includes things like not having on an artificial screen like a television, computer, and so forth, because even kind of mindlessly flicking through pictures on your computer, that is input. It's a high level of input and very fatiguing. So I recommend either sitting quietly for 20 to 30 minutes, or if they actually want to take the nap, taking that nap for that period of time. But it is going to be very patient dependent as far as how they feel length of time and whether or not it's just something that they can do for a quiet space versus something that they need to actually take the physical nap.
Have you had experience with color input for vision issues?
As far as, I'm going to take this from the standpoint of corrective lenses. If I'm mistaken, please type in and let me know. But yes, I have a lot of patients that work with neurooptometry, and we work with neuroophthalmology, and we found that there are certain tinted lenses that can help to reduce some of the input that comes through. So that also it's a huge help for neurogenic fatigue, because again, that's related to not only input, which vision is one of our main inputs, but also to output. So any referrals, any systems that you can bring into play to help reduce things that are basically draining water from that bucket, draining the system, are very, very important.
And you did clarify that was colored glasses and or yoked glasses.
Yes,
Okay.
yes.
We do have 3 other questions, Dr. Murphy, and I know it is right at 1 o'clock right now. If you have a couple more minutes, we may be able to address these now. Those of you who are able to stay with us online, you're welcome to stay online. Those of you who will sign off right now, please make sure to complete the evaluation that will appear as soon as the session ends. And all your certificates for continuing education credits will be sent in a follow-up email. So let's address these last few questions here. I missed some info between discussion of Wellbutrin, Ritalin, and DNRI and SNRI. Can that be repeated briefly?
So just briefly, as far as the usage for them, especially with Wellbutrin, I had just mentioned that in moderate and severe injuries it can decrease seizure threshold, so I tend to avoid it. The Ritalin and so forth are things that we use post-traumatic brain injury to help with things like sustained attention, similarly to how it is used in ADD and ADHD. And then when we're looking at the SNRIs, just mentioning things like, especially Cymbalta, which even though it is listed as an SNRI, we do know that it has some dopamine input as well. These are medications that we tend to use more than just the SSRIs because we know that they're hitting more systems and we can get more cognitive kind of bang for our buck with one medication.
Treatment effectiveness after the golden year.
Actually, you know, from my standpoint, and I know we do have, we have a rather lack of studies when we're looking at chronicity, but from everything we've seen, both clinically and with some of the studies we've had coming out, there are definite improvements that can be found after that golden year. And so I always feel that it's important, even if it's post 1 year, if there's still remaining symptoms, and these are treatments that have not been tried, it's important to try and get them done, but in tandem with the therapies. So I've had multiple patients that I've seen in my clinic that can be 2-3 years post-injury that we've started the amantadine for residual cognitive deficits, started them in speech therapy as well as, you know, physical and occupational therapy to work on cognition and fatigue, and we've seen improvements. We call it the golden year simply because that's the time for maximal benefit, but it's definitely not the end of benefit.
Which basically is the same type of thing. Can patients benefit from cognitive and language therapy past the 2-year mark if they are still demonstrating functional gains?
Absolutely, but again, I would highly recommend looking at the addition of the pharmacologic support in addition to the therapies, because if they're still having that market of a change and decrease in function, it's worth trying the medication therapy along with the actual physical and speech therapies in order to provide the maximum benefit.
And one last final one, what supplements recommended to improve quality and length of sleep?
So we mentioned melatonin, and as far as supplements are concerned, really that's kind of the mainstay that we recommend for treatment. But when we're looking overall as far as sleep quality, really we don't have a lot as far as supplementation for the sleep piece as much as we do for the fatigue piece. because remember, that's a balanced system, so that if you can improve the fatigue portion and you can have people more awake and more active during the day, there tends to be better sleep hygiene and deeper sleep at night. And so more often than not, when we're looking at different supplements, we're looking at, of course, replacing any vitamin deficiencies that someone may have, but then also working on quality for fatigue improvement so that they can then get better sleep in the evening. We'll do these last two questions, and then I think we're...
Okay, which foods help? Does emotional trauma generate long-lasting neurogenic fatigue?
So emotional trauma, we do know that we have enough studies that show that sustained domestic violence, sustained abuse, even in the absence of a head injury, can create the same physiologic changes within the brain that we see post-traumatic brain injury. So definitely there can be some sustained issues with fatigue and cognition after abuse. What was the other part of that?
Does emotional trauma generate long-lasting neurogenic fatigue?
Well, and I got that, the food.
Oh, which foods help?
So really I leave that as patient dependent, because there are a variety of different reactions that different people have to different food groups. And so that's why I recommend keeping the journal, because I don't give a blanket diet to anyone. I basically keep that very patient-centric and see what things they are responding to more positively and the things that they're responding to more negatively.
And the very last one, how does Butterbur work with TBI?
Oh, so Butterbur works with migraines, and we're not talking about pain and headache today. That's going to be one of our next lecture series. However, again, just like any other pain, it's very important to decrease overall pain because that takes away from the system and that adds to neurogenic fatigue. So that is a supplement that we use that has very good evidence for migraine prevention. So if there's somebody that's having concurrent migraines in the mix, because migraines can also cause cognitive issues, we definitely want to make sure we're treating them appropriately because it's going to help everything else.
So if you have any additional questions, don't forget that you can send them to our email address at uaa_ahec@alaska.edu, and we will forward them to Dr. Murphy. Susan, did you have a final?
I just wanted to really encourage everyone to fill out the evaluation because, as Amy mentioned, we're planning future webinars, and having your input is really important. And also, we really need to know if you're serving veterans either in an agency or in a private practice. So really appreciate that information and feedback, which allows us to then plan more programs.
So I wish to thank Dr. Murphy and Susan Maley and all of you for attending today's event, and most of you have even stayed over the few extra minutes. We do appreciate that. Now, certificates for continuing education credits will be sent in a follow-up email to all participants, and to help us provide the best trainings, please take a moment to complete that evaluation that will appear as soon as the webinar ends. The webinar is now over, and you may disconnect. Thank you very much.